everyone. Welcome. I know it takes a little bit of time for everyone to get fully into a Zoom room, to get audio working. And so this is the part of our Allcome webinar where I, Jessica Diaz, I work for the Oregon Health Authority. I'm here to just make sure we all get oriented into this space, this virtual space together, and spend a little bit of time talking so that you can test your audio and make sure you can hear me. If you're having any technical issues, please feel free to put something in the chat and we will help troubleshoot it. And we are continuing to admit more people. So I'm going to keep talking while we stabilize our group. And I start to see that people look like they're able to hear me. If someone can put in the chat confirmation you can hear me, also gives us a way to be a little interactive at the start of this webinar. Ooh, thank you so much. And I see people using the different emojis as well. Perfect. Thank you so much. And I continue to see people joining. Hope you're all having a good morning. And let's see here. Looks like we're starting to get there. Okay. Hi, everyone. Welcome to our November Allcome webinar. This is our quarterly webinar that is about the Oregon 1115 Medicaid waiver. Really excited to have so many folks joining us today. And in that vein, let's go to the next slide and talk about a little bit of housekeeping before we get into our presentation. Next, there it is. So we have quite a few people in Zoom. We will be recording this session today. So if you want to return to it later, want to send it to a colleague, you will have that opportunity. It also means that if you ask a question, it will also be recorded and will become part of that record. We also highly recommend chat as a tool to ask questions, to share information with us. It's a way to be interactive while also allowing the presentation to complete and for us to get through the content. So the chat is a great tool if you want to get our attention, if you want to share something that you've learned, if you want to ask a question. We also have the opportunity to use the raise hand functionality if you would like to raise your hand and ask a question. We, depending on where we're at in the presentation, we might finish the section of content and then return to questions and comments. One last tool that you all have is we can turn on captions. We have live captioning today. So if you look in your toolbar and you find that it's sort of a rounded rectangle with two C's in the middle and it says show captions, that will pop up captions as we speak today. And I see people continuing to join, but I think we have most of our folks for today. So I will go ahead and let's get into our content. Next slide, please. So our agenda today, we have a 6-part agenda. We're going to start with some slides that if you've been here before, you're probably pretty familiar, but we also want to make sure we continue to make sure we define our terms and we all start on the same page with a little bit of background information about the 1115 Medicaid waiver. Then we will have different topics and different speakers. So the Benefit Update Project, followed by a Reentry Healthcare Program update, an update on health-related social needs implementation, and sharing some health-related social needs housing data. And then we will close with an opportunity to ask questions and get some information about what to expect next. Next slide, please. All right, Medicaid waiver backgrounds. Next slide. Next slide, please. Oh, I think we went too ahead. You go back a slide. Thanks. Okay, so the very first thing is we want to make sure when we are talking about the Oregon Health Plan, we're talking about Medicaid, we're all on the same page. So Medicaid is a national public health care program that is also jointly administered by states. So each state has their own Medicaid program. Here in Oregon, we call it the Oregon Health Plan. So Oregon Health Plan is free health coverage for low-income children, teens, and adults who live in Oregon. OHP is open all year round and you can apply at any time. Next slide. When we talk about a Medicaid waiver, we're talking about, because this is a partnership between states and the federal government, there are federal rules that states follow to get Medicaid funding in order to have a program. But it is possible to ask to change rules and to try new things. And this is called a Medicaid waiver or an 1115 Medicaid waiver. And so those are ways that we can work to build a Medicaid program that fits in the context of Oregon, as well as to try out innovative ways of doing Medicaid that states can learn from one another and we can improve our programs. Next slide. And having gone through a very quick introduction, I'm going to next introduce Allison. Actually, I just introduced Allison. So Allison, please take it away.
Great. Thank you, Jessica. Good morning, everyone. As Jessica said, I'm Allison Evans. I'm here to provide an update on the Benefit Update project. So if we go to the next slide, just a little bit of background on this project. This project changes how Oregon Health Plan benefits are organized. So OHP will cover all services that are mandatory under federal law and that Oregon determines are medically necessary, or another way of saying that as services that are needed for health reasons. This change is primarily administrative and it does not change how OHP services are delivered. So if we go to the next slide, I just want to talk for a minute. As part of this project, Oregon's Health Evidence Review Commission, or HERC, has been reviewing some services not currently covered to see if they should be covered beginning in January 2027. The HERC reviews medical evidence to ensure services are safe and proven to work, and it considers other factors as well. And HERC staff maintain a web page, so you can look at all the reviewed topics at any time, and you can see that there on the slide. So if we go to the next slide, we can just see at a high level some of the new OHP services that we anticipate will be covered. So just noting at the top there, primary care visits will continue to be covered to manage any condition. And then some of the newly covered services include allergy testing, coverage for seasonal allergies, rashes, and then also services like physical and occupational therapy for more conditions. And so the example there is sports medicine treatment for a twisted ankle. And then also some newly covered eye and eyelid conditions as well. And then to see the full list of everything that's been reviewed in the work plan, you can see the link there, and we'll put that in the chat here in a minute. And then just one more update on the project on the next slide. Part of this work has included a work group. And we can see it on the next slide, just a little bit more details about that work group. It includes representatives from a wide range of organizations, including CCOs and member advocacy groups. We have been meeting since August, and we have 2 more meetings to come. And the work group has been discussing a wide range of topics, including appeals and hearings processes, the role of HERC, medical necessity, policy, and then other topics as well. And you can find more information about the work group and topics that we've discussed on the BUP webpage there. And then those last two links in the final bullet are links to register for the final two meetings, which will be on November 18th and December 2nd. Anyone is welcome to come to those meetings, and you can just follow that link to register and attend. All right, and then I just have one more slide just to provide a few more resources. So, and note how else you can get involved if you're interested. If you have any questions or suggestions, please reach out to the HERC team at any time. You can see their email there. And then other opportunities to participate in public meetings. There are the HERC meetings and the Pharmacy and Therapeutics Committee meetings as well. And the links for the HERC and PNT website are listed there. And then finally, just the BUP webpage again has a lot more materials about the project, including a fact sheet and FAQs. So if you're looking for more information, please check all of those sites, or you can email HERC at the email listed there. So that's it. Thank you all so much, and I'll turn it now to Jessie Wilson.
Thank you, Allison. Hi, everyone. Jessie Wilson, she, her pronouns. I'm the 1115 Waiver Strategic Operations Director, and I have a couple of updates here for y'all today, starting with the Reentry Healthcare Program. Let's go to the next slide, please. As some of you may be aware, with our latest, our most recently approved 1115 waiver spanning 2022 to 2027, Oregon did receive authority to be able to provide coverage for eligible individuals leaving a carceral setting up to 90 days of pre-release. That coverage included case management, medication-assisted treatment, and 30 days of medications in hand at release. So this is one of the authorities that Oregon did receive back in September of 2022 for our current 1115 demonstration waiver authorities. So just some background there. Next slide, please. I wanted to provide the update, and some folks may already be aware of this, but even though Oregon did receive authority to implement this program at this time during this demonstration, during this 5-year demonstration, we have made the difficult decision not to implement the 1115 reentry demonstration. This has been a difficult decision. There's been a lot of work that partners, members, community partners have invested in this work spanning several years, not just during this demonstration. And we are proud of all the work that our partners, community partners, have put into this effort. So it has been a difficult decision, but we are hopeful to continue to make progress in this area, and our goals certainly stay the same. I will share some efforts that we're going to be focusing on, even though it's not going to be for the 1115 reentry demonstration. We will be continuing work to help us move towards achieving our goals, and we'll be sharing that in the next few slides here. Let's go ahead and take a look at if you're wondering why we've made this decision during this time, it ultimately has come down to some pretty substantial barriers to implementing this authority, namely system limitations. To be able to implement this new program required substantial system changes to our Medicaid eligibility and enrollment systems, and kind of in parallel, the federal changes and current instability that we're experiencing with HR 1 being passed, those things happening in parallel have made it pretty challenging to be able to implement during this 5-year demonstration. So HR 1 had passed, and that also includes required changes to Medicaid rules and systems as well. So implementing these new rules also requires a significant amount of technical changes to our systems that we are required to implement by January 1st, 2027 for the entire Medicaid population. Let's go ahead and take a look at the next slide, please. So even though we are not moving forward with implementing the 1115 waiver, reentry waiver demonstration at this time during this 5-year period, we are going to be focusing on work to implement requirements to meet to the mandatory Federal Consolidated Appropriations Act, or FCAA, which includes providing Medicaid services to the eligible population that you see here on the screen. So individuals who are eligible under FCAA include individuals eligible for Medicaid or Children's Health Insurance Program, CHIP, individuals who are under 21 or under 26 and aged out of foster care system, post-adjudicated or sentenced, and then within 30 days prior to release from a carceral facility or within 30 days post-release from a carceral facility. So although this is not the 90-day limited OHP benefit that we would have been able to implement through the 1115 waiver, this allows individuals who are eligible to receive certain OHP services within 30 days prior to their release or within 30 days post-release from a facility. And those services, the eligible services, include targeted case management, screening and diagnostic services in alignment with early and periodic screening, diagnostic, and treatment, or EPSDT, within 1 week of release or as soon as possible after release. I do also want to note that we are pursuing in the 2026 legislative session a legislative proposal to be able to change state statute so that providers will be able to bill for Medicaid services for these individuals in the pre-release period. So currently, we do not have statutory authority for pre-release services to be billed to Medicaid. So we'll be working on that in 2026. Okay, next slide, please. If you have questions or you would like to read, have more information on the reentry healthcare, we have our website here, and welcome anyone to email our team with questions, or if you would like to have a conversation, we're happy to support that. Jessica, I think I'll pause there to see if there are any questions on this specific topic.
Yeah, and I see that there is one and that it has been answered. So I'll speak it out loud so we get it in the recording, which is, what does this mean for the health-related social needs program? And the response is that the reentry healthcare program changes should not impact HRSN health-related social needs at this time.
Yes, thank you so much for that question and for the response.
It looks like that might be it for now.
Okay, well, our next topic is on health-related social needs services. So I have an update here as well. Let's go ahead and take a look at the next slide, please. So just a reminder, if this is kind of a new term for folks, health-related social needs are social and economic needs that affect people's ability to stay healthy and well. Eligible OHP members may get these services, which are meant to help improve health outcomes. And we also received authority to implement these services in our most recent 1115 waiver, and started implementing these services back in March of 2024. And so far we have implemented the following that you see on the screen. Our benefits include housing supports, rent and utility financial assistance, home changes for health and safety. So that includes getting devices like air conditioners, air filtration devices, or home modifications like wheelchair ramps or grab bars, or heavy duty cleaning services. Also includes tenancy sustaining services, as well as outreach and engagement services, which are really to help the member to connect with other services beyond HRSN that they may need to support their well-being. We've also implemented the following nutrition supports: medically tailored meals and nutrition education. Next slide, please. So in terms of an update, we do have a housing eligibility update that we wanted to share today. On this slide, this shows a current high-level overview of the benefit eligibility for rent and utility financial assistance. So currently, individuals do need to be on the Oregon Health Plan, and they may be eligible for the housing rent and utility benefit if they are currently housed and renting, so cannot be a homeowner. And when they request the service from their provider or through their CCO or through OHA. If they're an open card member, that request for this benefit does need to include their lease or rental agreement. The individual also needs to meet the criteria for being at risk of houselessness, which means that they have a household income that is 30% or less of their region's average immediate income. And with their request, this income requirement also needs to be included. So that could include a paycheck stub or income tax return. The member also needs to need support and lack resources to maintain their current housing. So that kind of all is part of the at risk of houselessness definition. Lastly, they need to have a qualifying health condition. And the qualifying health condition is really where we are making update to the eligibility starting early next year. Just want to know, as part of the process, when a member applies for this benefit, that application is reviewed by their health plan to make sure that each one of these eligibility requirements are met. And if folks have questions specifically about this, we have a couple links here. More information can be found on our HRSN service provider webpage, and then our housing eligibility fact sheet as well. Okay, next slide, please. So as mentioned, we are going to be updating or refining our eligibility for the rent utility benefit beginning January 1st, 2026. So we are modifying the clinical risk factors for this benefit. And the reason behind this is that, as some folks may be aware, the volume and the need for this service is substantial, and to be able to best support individuals receiving timely access to this service, support our providers to have a sustainable business model, and really meet the needs of individuals, we are refining the clinical risk factors to include to really focus on acute and unstable health conditions that can be helped most with this short-term rent benefit. The rent benefit is limited to 6 months. So really looking at those conditions that would be best supported through that short-term benefit. We are not changing any of the population-based risk factors. So the first 4 bullet points here on the screen are not changing. So individuals who are meet the previous criteria on the previous slide and are very young, so younger than 6, individuals who are 65 years old and up, individuals who are pregnant and up to 12 months after the child is born, or young adults with special healthcare needs. Nothing is changing about the clinical risk factor criteria there. Where we are making some refinements is really on the specific health conditions, and we're focusing again on acute and unstable health conditions that can be most helped by a short-term rent benefit. So what does that mean? Narrow to acutely unstable health and higher risk chronic health conditions, as well as adding the requirement to have engagement in healthcare services for these health conditions. And we did, I will just say, share this proposed update in our Rules Advisory Committee earlier this fall, and we're continuing to refine what those proposed rules will be, and we'll be releasing those very soon, and those will be in effect January 1st of 2026. Let's go to the next slide, please. The final update for HRSN benefits, I wanted to take some time to discuss our plans for the nutrition benefit. So as you know, or as I mentioned earlier, we have currently implemented medically tailored meals and nutrition education. We will be launching 2 new nutrition services for eligible OHP members in the summer of 2026. So I'm excited to share that we'll be launching the pantry stocking benefit, which will allow eligible members to receive foods aimed at promoting improved nutrition. We'll also be launching the fruit and vegetable benefit, which will allow eligible members to receive produce from participating food retailers, vendors, and farms. So more to come on this, but aiming for a launch of summer of 2026. Also want to highlight that both of these new benefits will be able to be provided at the household level for eligible members who are pregnant, who are a child under 21, or a young adult with special health care needs. So we'll be able to scale the benefit to the household size for those eligible individuals. And I think that is it for the implementation updates. But Jessica, do we have any questions that we want to take at this time?
Yes, let me see here. It looks like there was a question about housing benefit if someone owns a mobile home but rents the space for it. And Charissa has responded that rent for the land may be covered if the member is otherwise eligible and pointed to a specific Oregon administrative rule and table to reference that eligibility. And let's see here. There's a question about required engagement in healthcare services. Is that a question that you have an answer for?
I can expand on that. So some examples of what that could look like could be the member has a scheduled surgery in the upcoming 90 days. They have hospitalization in the past 365 days. Mental health, psychiatric, or substance use disorder residential treatment, intensive outpatient services within the past 365 days, recurrent emergency department or urgent care visits in the past 365 days, or increased frequency or high utilization of outpatient services or supports. So those are some examples that we've listed in rule. I'm happy to provide, we're working on some resources to help clarify the rule language kind of in some leave behind type of format. Does that answer the question that we have in the chat?
It looks like it does.
Okay, great. Thanks for that question.
And next up is someone asking, where can we learn more about the fruit and vegetable benefit? And then another question about pantry stocking.
Well, this space is a great forum for learning more about the benefit. But Shauna, I'm wondering if you have some resources that you could share with folks or some indication of upcoming resources that would be helpful.
Oh, good morning, everyone. I'm Shauna Care, she, her pronouns, and I'm one of the operations and policy analysts on the waiver team. We are finalizing some rules right now that will help support both the fruit and vegetable and the pantry stocking program. Those will be effective January 1st. So we'll be able to provide more information within the next, I would think, 2 months. It'll be, we'll post more information on our websites and be able to come back to this forum along with the provider forum and to be able to provide more information. So we are getting there. I would expect 6 to 8 weeks before we're able to post some updates within our website. So it's coming, but we're just putting some of the finalized information together so that we can have robust programs and be able to provide more information. So I hope that that's helpful.
Thank you.
Thank you, Shauna.
And then we'll make sure to put in resources and websites into the chat directly because I see that there is interest in getting that more directly. There is a question about changes in the housing benefit for people who have experienced domestic violence in the past 12 months.
Yeah, thanks for that question. That is remaining as a qualifying clinical risk factor. We are refining that language a bit in rule. So there will be some slight language change, and I can preview some of that now. So individual who is has experienced DV in the past 365 days or has experienced DV resulting in child welfare involvement in the past 365 days. So generally, not too much change there. That is remaining as a clinical risk factor, but some slight refinement to the language in rule to clarify. Thanks for that question.
I think this is a topic that has resonated. There are more questions than we have for some of the other sections, but I think maybe a couple more and then we move on. Does that sound good? And we can circle back at the end as we have time. So the next question is about what is the best way to escalate an issue with HR and housing benefits if they have an approval letter and are facing an eviction?
Yeah, thank you for that question. A couple of recommendations. Folks are welcome to reach out to the Ombuds team and we can put the contact there, and also encourage individuals to share that information. If there's an update to their situation where they're facing an eviction, share that with their HRSN service provider and their CCO as well. We can put the Ombuds contact there as well, who are member advocates and can help support connecting with health plans as well.
And then I recognize there's more, and so I'm going to do one more, and then please continue to put in questions, and hopefully we'll be able to address them after we've gone through the next piece of content. But and I'm going to paraphrase this slightly. If someone applied for HRSN and then they change their CCO, I think is this question. What should they expect or what should they do?
If someone has applied and then changes the CCO, or okay,
For HRSN.
Yeah, a couple different scenarios. If they're already receiving that benefit and they're in the middle of receiving that benefit, so for example, rent, perhaps they're 3 months in, and they are changing their CCO. If they haven't moved addresses, they're still at the same residence, they're just moving to a different CCO, then there is a transition of care process where the receiving CCO will get information and be able to continue that benefit. If you haven't received, or if the individual hasn't started receiving that benefit, there's a process in place, or they've been authorized and haven't received it. Same thing, that information from that CCO who's authorized that service should be able to share that with the other CCO so the individual doesn't have to start completely over with that application. If that application has not been authorized yet by kind of the original CCO, then that individual may have to reapply again with their new CCO because the former CCO wouldn't have gone through that process and collected all the information yet to be able to share. And I welcome my colleagues to add any details that I may have missed. Thanks for that question.
Because there are so many questions, I'm going to pause questions, but we will continue to work down the chat. So Jesse, if you want to continue.
I think this is our last slide, and I was going to turn it over to my colleague Anna to share a data update.
Thanks, Jesse. Hi, everyone. My name is Anna Menon. I use she, her pronouns, and I am the HRSN analytics lead at OHA. And I come to you today with a little data update. So we can go to the next slide. So we have some new data to share on the HRSN rent and utility benefit specifically. So this benefit launched November 1st, 2024, and we currently have data through the end of June 2025. So in that time period, There were over 12,500 members who were requesting these services. Over 6,000 were ultimately authorized for rent and utility supports, and almost 4,500 have received the rent and utility benefit. Now, I do want to note that all of these numbers are still preliminary and may change. We heard from a housing provider in Klamath County that shared about the huge impact that the HRSN rent and utility benefit was having on families. They shared that the availability of the HRSN benefit in Klamath County has stabilized many families and individuals, keeping them off the streets or out of the one available shelter in our community. This benefit has so far kept 74 families and children from becoming homeless. You can go to the next slide, please. All right. We're seeing that organizations are still enrolling to become HRSN providers. From July of 2024 through August of 2025, we have 174 providers enrolled as HRSN housing providers with the Oregon Health Authority. And these enrolled providers are serving both our CCO members and Open Card members. There were massive outreach efforts pre-launch, so just before November, in the form of roadshows, which resulted in the significant bump in enrollment you see leading up to November of 2024. And OHA is still engaged in continuous outreach efforts. The uptick you see in August, enrollment may be the result of staff outreach to 30 organizations in July of this year. And we'll be able to see in the coming months if newly enrolled providers are beginning to deliver housing support services. All right, we can go to the next slide, please. All right, so this map shows the number of housing providers that are delivering services in each county. So providers may be located within the same county or outside of it, and providers can, of course, deliver services to more than one county. So the darker the color, the more housing providers currently delivering HRSN rent benefit in that county. So from November 2024 through June of 2025, a total of 79 organizations provided HRSN rent and utility benefits across the state. And we see that providers are delivering services to members in every county besides Wheeler County. And that's because Wheeler County has no claims for rent and utility services, but members in Wheeler County do have claims for other HRSN service domains. Okay, we can go to the next slide. So from November of 2024 through June of 2025, a total of 4,490 unique members have received the rent and utilities benefit. The graph on the left shows the total count of members served by health plan, and the graph on the right shows the rate per 10,000 members enrolled in each plan. So the rate per 10,000 enrolled members is looking at the overall plan membership and really doesn't take into account any differences that may exist in eligibility for the HRSN rent benefit between the plans. So the graph on the right really allows us to compare members accessing the rent and utility benefit between the big and small health plans. So we see that even the smaller health plans are able to make a really big impact in their community serving members. And we can go to the next slide. So this is a map of Oregon counties showing the rate per 10,000 OHP members who have received the HRSN rent and utility benefit in each county. So it's like the previous slide, like the graph on the right. So we're showing rates here. Like the graph on the last slide, this allows us to compare counties with very different population sizes to better understand localized impact. So we see here that the rent and utility benefit has a particularly high impact in counties in the Northeast, Wallowa and Union County specifically, and in the southwest and coastal counties, looking at Coos County, Curry County, and Josephine County. And I think that it's all my slides, unless there's any questions.
And I see we have a lively chat, but I'm not sure. Anna, can you help me see if any of them look like they are directly relating to your content? And we can start there if you.
Sure. I see a question directed to me about direct contact for potential new providers to actually speak to someone. I might push that over to Jessie to see if she can answer that one.
Yeah, absolutely. Thanks for that question. I was just in the process of writing a response, Chauncey. You can reach out directly to OHA's HRSN program, and I'm going to put that email address in the chat. So we're happy to help discuss, the process for new provider enrollment, and kind of the difference for doing that for OpenCard, which is through OHA, or contracting with a CCO. So yeah, let me put that in the chat, and feel free to let me know if there are additional questions.
Thank you. I believe, I also want to check and see. I don't think we've had any raised hands today, but if anyone would like to ask a question out loud, that's also absolutely an option. Oh, and I do see a question specific to data. Wondering if you have info regarding demand per county.
Yeah, so I think that would be looking more at the request data and where the requests are really coming from. So we have looked at requests by plan. I don't believe we have yet analyzed that by county. But that's a great call out, thinking we could tell that a little bit as it relates to member demand for the services.
Thank you so much. Okay, I think we can move on. Which brings us back to the general Q&A. And I have to admit, Zoom has changed how it works when I look at it, and now as people respond, it's moving the questions and comments out of order. So I'm going to take 1 second to try to reorient myself to some of the things we haven't yet spoken to out loud. And I believe the first one on this list that we haven't yet spoken to is asking about the transition for when Pacific Source leaves Lane County. I'm not sure if we have HRSN specific information that's up, but I did share a link to a website where OHA is putting up more general information about that transition process and what to expect. And that link is also where additional information will be shared. I want to check and see if any of our presenters have anything they'd like to add on that topic. Okay.
We'll be sharing more information as we have it, but thanks. That's a great starting point resource, Jessica.
Someone asked about a list of rent and utility providers per county. And I think the answer is that we don't necessarily have a per county list that is maintained centrally, but each health plan is required to include health-related social needs providers in their provider directories. And I am scrolling. I think, this is I should pause and check in with our participants. Did anyone ask a question that didn't get answered, or did these questions and answers bring up new thoughts that you'd like to share? Oh, it looks like some of the links are getting harder to access. So if I can ask folks to make sure that the links we've shared are posted perhaps one more time. And there is a question I'm gonna say this one because I'm seeing I missed it earlier, but I also see there is a raised hand. So there's a question about child welfare and APD showing substance use disorder and behavioral health residential program involvement in the last, let's see, and my apologies because there are some, I'm not sure I know what IOP, the acronym means. I'm gonna check with everyone else. You know, I get so used to my acronyms and then I find a new one and I suddenly realize how everyone else feels when I speak in acronyms. Um, there is some clarification on this, which is that I'm gathering there are situations where intense outpatient treatment. Okay, thank you so much. Annabella, can I ask you actually to speak out loud to this for us as I struggle? I'm so sorry.
Yeah, you're good. It's a very complicated thing. I was just asking, this is a very sensitive thing. I work in the recovery support team for child welfare specifically, and we were kind of worried about our child welfare involved parents, being that we have a very sensitive houseless population, and our pregnant and parenting population is very vulnerable, being we have a very small window of trying to get them into residential treatment with their child to parent, and the able-bodied um, avenue is scary for us, being that we are afraid of clients losing their coverage because of court involvement and because of them losing their children in care, them becoming single. And once they're court involved, getting their children back is a lot harder once they have to prove treatment involvement, right? And so I was just kind of wondering if you guys were going to have a very specific outline for the qualifications and disqualifications of any repercussions of what would be needed for that vulnerable population. It was very important to me to know those going forward. And I know Sarah Caldwell is also on this call, and she works with us as well. But um,
Thanks so much, Annabella, for that question. So I think I'm gathering that the concern is how to provide evidence of engagement in those supports as a qualifying clinical risk factor. Is that the
yeah,
issue?
yeah, we just want to make sure that we're trying to gather as much evidence as quickly as possible, being that the time frame is usually very short, and we don't have a lot of resources at hand. So any guidance that you guys could provide so we can sort through that quickly.
That's a great question. So thinking through kind of the process, a member applies for rent and the health plan is conducting that screening, looking for a qualifying clinical risk factor. What sort of communication could we support from the health plan to child welfare to help ensure that any information is not missed in this process? Do you have thoughts on that? And happy to follow up with your team offline too to kind of think that this situation through to make sure we can support.
Yeah, I know we have a lot of avenues. Um, being that, so like for instance, our team is a program offered by Referral Base, and Sarah Caldwell also works on the Family Services team, which is also a referral based program. So we're kind of involved as a third party, even though we're associated with child welfare. And so I'd say it is difficult. We're kind of thrown in the emergency trauma factor. Avenue wise contact, I'm not really sure how we would I'm saying is because it's like usually we are just kind of emergency trying to triage problems. And um, sometimes when we get our clients, they don't even have OHP established. They have to reestablish it. And knowing that the timeline right now is a 6-month renewal every 6 months is kind of I don't know.
What are your thoughts on having a follow-up meeting to discuss? I want to make sure that we're understanding the concerns and I don't have all the information from me right now. There may be some information that we can leverage, and we can also talk to CCOs about this too.
Yeah, I think that would be a great idea.
Okay. Thanks so much for bringing that up. I will put, well, do you want to reach out to the HRSN program email? I can put it in the chat again and we can go from there.
Sounds good. Thank you so much for taking my question and
Of course.
allowing me to broadcast that.
Thanks so much.
Thank you. Katrina, I see your hand is raised.
Hi, thank you. I apologize in advance if this is not the best place to ask this question. It's regarding the new fee schedule for HRSN. So I am an HRSN provider and I got some invoices sent back to me that have the old fee schedule, but the date of service was after the new fee schedule. So I'm not quite for sure if anyone can comment regarding that or if there's a better place to follow up regarding this.
Yeah, is this for rent and utilities?
This is for O&E and tenancy. So the invoices and the date of service was after November 1st, but they're being sent back and adjusted for the old fee schedule.
Okay, if the date of service that services provided is after November 1st, then the new fee schedule, the $26 per 15 minutes should apply. If it was accrued, if the work was done before the 1st, then it would be subject to the former fee schedule, the $20 per 15 minutes. So it sounds like these services were provided after November 1st.
Yes.
Okay.
Yes. So would I need to follow up with the CCO?
Yes, I think that would be
Okay.
appropriate. And if there may just be some clarification there. I don't know if they will request additional documentation, but yeah, anything provided after November 1st for tenancy and O&E subject to the new fee schedule.
Okay.
Thank you for that question.
Thank you.
Thank you. There's a question around clarification on those different scenarios. It looks like specifically when a member moves but is staying within the same service area with their CCO. In the process of OHP getting the updated address versus the CCO moving forward with a decision.
Sorry, I was trying to find the question in the chat. I'm not sure if this is part of the question, but if an individual moves and they're receiving the HRSN rent benefit, they would no longer be eligible to continue to receive the rent benefit at their new address. So the 6 months of rent is to support the individual to stay in their current housing. So if they opt to move, if something happens and they move, then that benefit unfortunately would not be able to be continued at their new address. I don't know, Jessica, does that answer part of the question? I'm trying to scroll through the chat to find.
Yeah, this might be an opportunity, Diane, if you'd like to speak with us directly, that might be a good way for us to answer this question. And I don't see if it is specifically housing HRSN or a different HRSN service in this question, but I might be missing it.
Oh, okay. I found Diane's question. Just taking a moment to read it. So, Diane, if someone has applied for rent, hasn't received the service, and then they move, um, they do need to essentially reapply again, because the components of the eligibility would be different. So you would still need to get the new lease agreement for their new residence from that property manager. I think as part of, best practices, customer support, there could be some expedited processes that health plans can integrate into that. The clinical risk factor should still be honored, of course. And if they're an OHP member, obviously that hasn't changed, but the pieces of the landlord side really need to be verified again. So does that help answer? And if I welcome you to come off mute and talk through that if you need additional clarity.
Yeah, I'm just wondering if the work would be mainly on the CDO side, because they're the ones that when the member has communicated that they've left, they're notifying us that the member moved before receiving any funds. And, they could do the work of obtaining the lease from the approval that they've already received. It's just the process of going through a whole nother authorization on the CCO side that seems like it's unnecessary.
Yeah, I hear you. And so to your first point, I do think that's a great role for the CBO to play, supporting that member through O&E to obtain that additional documentation. I think we can talk about that in the CCO work session on, how to best streamline for that scenario.
Yeah, it's just that, they really need another authorization number and new referrals.
Mm-hmm.
The only thing I can think of is if their bedroom size changed, then they would need new referrals through Unitas for the caps to be correct. That's the only thing I can think of as far as a new authorization and new referrals.
Yeah, I think we can dig in on that process. And if the only thing that's changed is the address and everything else is the same, the upper payment limit, the size of the unit, nothing else has changed there, then happy to talk through kind of what, I don't know if you can update things on your side and not have to kind of go through the full authorization process. But yeah, let's take a look at that situation and see what where we can streamline.
And because it is 10:58, I think I'm going to, let's see, there was one last question about data and the trajectory, and I see that it has been answered in the chat. I will read it out loud really quickly, and then I will go to the final slide so that we have those next steps. Data through June shows that utilization remains high and has grown steadily from November. Eligibility changes have been data informed, and we plan to closely monitor the impacts of the eligibility changes on requests, approvals, and utilization in the coming year. I am going to ask for the next slide to make sure that I get to that, which is that we do have different emails that you can use to contact the different teams working on reentry healthcare, health-related social needs, and benefit update project. Ooh, I can talk. And we also have our waiver renewal website that has a lot of information. And we continue to have an email listserv that you can subscribe for updates. And so these are all good ways to stay connected with us as we go into a new year. And I think that should bring us just about to the end. We are working on we will probably have a new link for webinars in 2026, so stay tuned for more information. And I think that on the dot for 11 a.m., thank you so much for joining us today. We hope that you found this time over the last hour useful. We've really, thank you so much for asking very, very good and nuanced questions. And thanks for your continued participation. We hope to see you again next year or otherwise through more one-on-one conversation, but look for next year opportunities such as this one to be shared very shortly. Thank you all, and thank you to all the presenters. Thank you to our captioner. Have a good rest of your day, everyone.